Good morning, good afternoon, and good evening. Thank you for attending the KAP COVID dashboard webinar. I'm Elizabeth Solomechos. I'm the project director for Breakthrough Action, USAID's global flagship project on social and behavior change. The project is led by Johns Hopkins Center for Communication Programs. We're excited to share this latest global dashboard on vaccine acceptance with you and to take an in-depth look at the trends on the two-country contexts. Then we will hear about the practical tools for thinking about social norms and vaccine messaging, COVID vaccine messaging. Before I introduce our moderators this morning, I would like to go over 3 housekeeping dynamics. First, please note that we have simultaneous French translation occurring. I am going to advance the slides to show our French speakers how to access the interpretation channel. Pour vous qui sont les francophones, choisissez votre langue préférée. Il y a les instructions là au-dessus dans le diapositive. Second, please use the chat room to greet your colleagues. Several of you have already done this. Please introduce yourself and let us know the diverse range of countries that you are representing. Thank you. And third, as the presentations occur, use the Q&A tool at the bottom to submit your questions for the panelists. You'll see the name of my colleagues on the webinar today who can help you with any technical issues. Some of the questions will be responded to in the Q&A tool, and others will be pushed to the panelists for the open discussion. Now I'd like to welcome our moderator for today's panel, Dr. Rupali Limaye. Dr. Limaye serves as a full-time faculty member at the Johns Hopkins Bloomberg School of Public Health in the departments of International Health, Epidemiology, and Health Behavior and Society. Widely seen as an expert in vaccine behavior and decision-making, including vaccine hesitancy and acceptance, she serves as the Director of Behavioral and Implementation Science at the International Vaccine Access Center, as well as the Associate Director for Behavioral Research at the Institute of Vaccine Safety. Dr. Limaye, welcome.
Thank you so much, Elizabeth. It's really great to be here. Thanks for all of the folks that have joined so far. And as Elizabeth mentioned, please do engage in the chat. We'll try to be looking at that and trying to respond to questions as they come. So I'm going to start with just a couple of very, very broad comments and then really get into the meat, I think, of why we are here today. So a couple of things. I want to talk very broadly about vaccine behavior. I know many of you are social and behavioral scientists and practitioners, which is great. But one thing I want to be very clear on as we're talking about specifically COVID vaccines is that behaviors related to vaccines very much fall on a continuum, right? So we have individuals that might refuse some vaccines, might accept others, might accept specific vaccines, but may have questions or concerns about that vaccine. And so it's very important for us to understand that there are a number of segments, I would say, with regards to the types of behaviors related to vaccines. The second quick point I want to make is that vaccines, while we have had an amazing scientific, robust process that has resulted into where we are today, we know that vaccines do not save lives, but vaccination saves lives. So that means that we need to make sure that people know, 1, that they're available, 2, they need to think that they are safe, and 3, we need to make sure that they have the information that they need to make an informed decision with regards to whether or not to accept a vaccine. The third and last point I want to make very broadly is that many of us have been tracking vaccine acceptance over the last year, particularly when the pandemic started and there was talk of an idea that there could be a vaccine product within imminent, essentially, hopefully within the next year. One thing that we have seen over time is that there has been wide variance in willingness to get vaccinated. An example I will give you is that we have been tracking numbers from individuals that live in Russia, for example, where acceptance and intentions to get vaccines have been low over the last year consistently. And we compare that to, let's say, a country like China, where we see high rates of vaccine acceptance and intention to get a COVID-19 vaccine once it is available in the country. The other key thing I will say here with regards to acceptance, and I'm excited to then move to the presenters, is to talk a little bit about disparities and this idea that we are starting to see pockets of hesitancy and really issues related to safety concerns among specific populations, not only here in the United States, but that's also globally. So that's in lower and middle income countries as well. And I think the key here, especially from a behavioral and social science perspective, is how do we nudge individuals towards vaccine acceptance, particularly among those communities that are already facing disparities. So again, thank you, Elizabeth. Thank you, Breakthrough Action, for allowing me to be here today. I am excited to introduce our first two panelists. So let me start with Dominic Shatak, who is the Director of Monitoring, Evaluation, and Learning for the Breakthrough Action Project at the Johns Hopkins Center for Communication Programs. He also co-leads the KAP, the Knowledge, Attitudes, Practices COVID survey, as well as the data utilization efforts. And this is in partnership with Facebook, MIT, the WHO, and GoARN. Since the start of the pandemic, his work has really been informing global program implementers and policymakers about risk mitigation behaviors, as well as trends related to vaccine acceptance. So Dominic, welcome. It's great to have you here. I'm going to quickly also introduce Dr. Doug Story. So Dr. Story is the principal investigator for the KAP COVID study. So he is a behavioral scientist with nearly 40 years of work in health communication and social and behavior change communication, most of it in international settings. He has lived and worked in more than 36 countries on a number of issues, health and environmentally focused. This includes social and behavior change related to reproductive health, family planning, maternal and child health, child survival, nutrition, malaria, HIV, gender. And so Dr. Story has provided behavioral insights into the KAP COVID dashboards. And so Doug, welcome to you all, and I'll turn it over to Dominic and Doug.
All right, thank you. If you'll go to the next slide, please. And the next one. All right, so as mentioned earlier, this is a collaboration between Facebook, the World Health Organization, MIT, GORN, and Johns Hopkins Center for Communication Programs. We thank you for attending the webinar today, and Doug and I are going to talk through some of the recent data from Wave 15 of the KAP COVID survey. First, I'll provide a brief overview of the overall KAP COVID project, and next I'll describe some of the changes in COVID prevention behaviors in two countries, Egypt and Pakistan. Then Doug will continue to describe their vaccine acceptance data. There may be some questions about the survey implementation and methods. I'll only talk about those things for just a moment. For more information, please visit our website, which has the appropriate links to documentation and a manuscript that will provide more information about those methods. If you go to the next slide. This table reflects our sample to this point in the study. This is a repeated cross-sectional survey. It's possible that the same people have answered the survey more than once, but that is not something that we are tracking. At this time, there have been almost 1.7 million participants. And it's important to note that there are two types of countries in this studies. There are 67 snapshot countries that were surveyed twice, in July and again in November. And within those 67 countries, there are 23 countries that were surveyed at every wave. If you go to the next slide, please. The survey includes 64 questions. There's a random assignment scheme within the survey's algorithm, so not every participant sees every block of questions. And this was done to minimize the survey length and to reduce participant discontinuation. We've listed out the domains that this survey covers here, and you can learn more about the survey and get the survey documentation from our website as well. If you'll go to the next page, please. I wanted to take a moment to describe the vaccine questions within the survey. When the survey began, question 1 was administered, asking about vaccine acceptance with a yes, no, don't know response option. Later, during wave 9, we added 3 more questions about vaccines. We included a second question asking about vaccine acceptance using a Likert scale, and 2 more questions, one about vaccine norms and another asking which information channels might influence an individual's behavior toward getting vaccinated. To be clear, we have 2 different vaccine acceptance questions in the survey since wave 9, and Doug will talk more about them in a few minutes. Let's take just a moment to link these dashboard updates to the RCCE strategy. Go to the next slide, please. As mentioned in previous presentations, we view the dashboard as a data utilization project. We hope that these dashboards facilitate ministries of health and their partners to take action locally. These local actions will contextualize the findings, drill into the subgroups and segments that were probably mentioned earlier, and test the messaging. If you go to the next slide, please. We know vaccine distribution is not the same in each country. And in many countries, it may be several months to a year before distribution is significant enough to reach herd immunity levels. Therefore, continued maintenance of COVID prevention behaviors are key to limiting spread. If we go to the next slide, please. Experts around the globe are suggesting that this is the moment when prevention behaviors need to continue. As the vaccines roll out, there's an increased fear of pandemic fatigue due to decreases in perceived risk, increased financial and psychological impact of quarantine, and also we can get complacent and just kind of let our guard down. If you go to the next slide, please. So over the next few slides, I'll touch upon factors typically associated with prevention behaviors and their changes over time. The graphics presented will use data from Egypt and Pakistan, just as a reminder. If you'll go to the next slide. These graphics come from the KAP COVID trend analysis dashboard. We have several different dashboards on the landing page when you get there. The link will be shared in the chat in a moment. A new wave of data is being entered into this dashboard and also in the vaccine acceptance dashboard today. So please visit those resources for updates. Please go to the next slide. Beliefs and fear of negative health outcomes often drive prevention behaviors. This slide reflects changes in beliefs related to COVID-19 in Egypt. Since July, participants' responses reflect increased concern. This slide depicts a 7 percentage point increase in perceived threat that COVID presents to their community, and a 9 percentage point increase in the belief that people like them are likely to become infected. Among rural participants, the shift in this fear was 18 percentage points. Typically, we would expect to see as perceived threats increase, health prevention behaviors also increase. Please go to the next slide. Social norms are another factor associated with prevention behaviors. Research has shown that how a person perceives behaviors in their community will influence their own behavior. For example, do they believe that the majority of people are wearing masks? Do they believe the majority of people are physically distancing? If so, they may be more likely to also wear a mask and physically distance. This graphic presents norms around both of those prevention behaviors. The overall change in physical distancing norm was very small, a 2 percentage point increase, while the perceived norms of mask wearing increased by 8 percentage points since July. In the table on the right, we can see how the mask wearing norm increased dramatically among rural participants. So in the last two slides, and we've seen that participants from Egypt reported increased concern that COVID is a threat and perceptions that mask wearing in their communities has increased. Fortunately, next slide, please. Fortunately, mask wearing was already high in Egypt at over 80%. Rates of mask wearing didn't fluctuate significantly since July. To the right, you can see gender and residence differences in these data for both hand washing and physical distancing. Officials in Egypt may want to look further into these relationships between beliefs, norms, and behaviors. They may also want to investigate the role of pandemic fatigue and disseminate messages that encourage continued hand washing and distancing. Let's take a quick look at similar data from Pakistan. Next slide. These are the trends in COVID-19 beliefs from Pakistani participants. While 2 of the trend lines decreased since July, there was a 9 percentage point increase in reported fear of serious illnesses. Looking more closely at the sex disaggregated data, we can see that women and men's data changed differently. Women's perceptions about COVID as a danger to their community decreased, while men's increased. Women's fear that someone like them could get infected decreased. About half of men and women fear serious outcomes if infected. Looking at the change since July, we can see a 13 percentage point increase for men. Next slide, please. Perceived norms associated with mask wearing dropped 9 percentage points, while physical distancing norms dropped 6 percentage points from July. Looking more closely, this drop was most significantly seen among women. In the table to the right, we can see a 15 percentage point reduction in perceived mask wearing and a 14 percentage point reduction in perceived distancing among women. Keeping this in mind, let's take a look at the changes in prevention behaviors. Next slide, please. This slide presents the change in reported prevention behaviors in Pakistan. We can see that all three behaviors reduced over time across almost all the demographic groups. As beliefs about and the norms reduced, as beliefs and the norms reduced, so did the reported prevention behaviors. Pakistan's data reflect important changes in beliefs and norms. Prior to message development, officials should further explore the relationships between norms, beliefs, and those desired outcomes. These dynamics need to be unpacked locally. If you go to the next slide, please. Before Doug begins, I wanted to briefly summarize my slides. So the KAP COVID dashboards provide an interactive tool to view data. Interpretation will need additional contextualization at the country level. And it's important to consider both changes in behaviors and the factors driving those behaviors, like beliefs and norms. There are several other things as well, but we'll focus on those for now. When considering how those factors change, messaging systems must be dynamic and make adjustments to effectively engage beneficiaries. So at this point, we'll go to the next slide and I'll hand it over to Doug, who's going to continue talking about vaccine acceptance.
Thank you, Dominic, and good day, everyone. It's great to be with you today. So I'm going to run through some of the results from the vaccine acceptance section of the dashboard. Could I have the next slide, please? So sort of globally, if we look at the rates of acceptance, we're seeing a decline over time, about 5 percentage points from July last year, 3 percentage points since January. And this is in spite of the fact that prevalence rates were rising during most of this period. But when we look more closely at specific countries, we find that these rates do vary considerably. And we're going to just consider Egypt and Pakistan again today as a way of illustrating that. Next slide, please. So in Egypt and Pakistan, we are seeing a decline in overall acceptance. We had several different levels of stated acceptance. People could say that they definitely would accept a vaccine when it becomes available, or they probably would accept a vaccine when it becomes available. They were also able to state uncertainty about acceptance. And then they could also express reluctance or resistance to accepting a vaccine by saying probably not or definitely not would accept over time. Next slide, please. If we look a little more closely at this trend in Egypt, there are some data at the bottom here that sort of point to the things that we're highlighting on the screen. But overall, the vaccine hesitancy in Egypt, it has increased from 13 to 20%. Those are the yellow bands that you see in on the figure. The unsure responses, the gray, also increased 7 percentage points, but it remained fairly consistent at about 20% of participants. And the percentage who said that they would definitely accept or probably accept the vaccine when it becomes available, also declined from 73 to 58%. And the biggest drop was in that definitely yes category, the dark green category that you see on the figure. Next slide, please. We can drill down a little deeper as well on this, look at some demographic breakdowns. On the right of the screen, you see the percentage of younger, 30 and younger, and 31 or older, those with college education or more compared to those with a secondary education or less, those who live in rural areas, urban areas, and men and women. And some of these demographic categories don't really differ very much. There's not a great deal of difference in terms of age. Again, we're talking about Egypt at this point, but there are some differences in terms of education level. Those with more education in Egypt are less likely to express willingness to accept. Those who live in rural areas are a bit more likely to say that they would accept a vaccine. And women are less likely than men to say that they would accept a vaccine. Now, an interesting sidebar here is that in Egypt, about 58% of people say that they will get a vaccine when one becomes available. This is well below the threshold of 75% that's generally regarded as what's necessary for herd immunity. But 48 out of 100 people think that the acceptance rate is that acceptance is a majority opinion. So that you see a difference between the percentage who say they would accept a vaccine and their perception of what other people are willing to do. So there's a gap here between the perceived reality and the personal acceptance rates. Next slide, please. And this just illustrates in a little more detail what I just noted before. Across age, particularly across age and residence, that is urban versus rural residents, acceptance rates are relatively stable, but people with less education reported higher levels of vaccine acceptance, and women had lower rates of acceptance than men. So again, this begins to suggest some directions for strategies about which subgroups may require more attention when a communication strategy is developed. Next slide, please. If we turn our attention to Pakistan, again, looking at wave 15, in the January data, there is generally consistent or somewhat more stable opinions about vaccine acceptance in Pakistan compared to Egypt. But there have been some recent increases in non-acceptance. The vaccine hesitant group, the yellow bars at the top, increased by about 3%. So hesitancy has increased slightly. The unsure group increased by about 2%, 2 percentage points. And those who say that they would accept the vaccine decreased from 75 to 70%, with the biggest shift being in that definitely yes category, the dark green category here. Perhaps we could take some comfort in the fact that there is some suggestion that perhaps that trend in acceptance may be shifting a bit in a positive direction, but time will tell. Next slide, please. Again, some examination of demographic breakdowns and acceptance rates. We, again, don't see the differences as strongly as we did in Egypt, but there is still some evidence that education makes a difference. But in this case, those with more education in Pakistan say they are likely to accept the vaccine. And those who live in urban areas are more likely to accept a vaccine. The other demographic breakdowns really didn't vary very much. But again, in Pakistan, we see, just like in Egypt, a difference between what people say that they would do. 69, 60, almost 70% say they would get a vaccine when it becomes available, but they perceive that the community norm is somewhat lower than that, about 51 out of 100 people. So there is a gap between what people say they would do and what they believe other people are willing to do. And again, that suggests some interesting options for communication strategy. Next slide, please. And this drills down just a little bit, in a little more detail on what I just mentioned. Those with lower levels of education express lower levels of acceptance and higher rates of refusal. Acceptance is higher in urban areas, and men are more likely to refuse or say that they would decline to accept a vaccine compared to women. Next, please. Among the other things like threat perceptions and so on that Dominique was mentioning in the earlier part of this presentation, another factor that can influence whether someone is willing to accept a vaccine is who they take their advice from, who they are influenced by in making a decision about whether to accept a vaccine or not. The question that was asked was, would you be more or less likely to take a vaccine against COVID-19 infection if it were recommended to you by a variety of sources, by friends and family, by health workers, by the World Health Organization, by government officials, and by politicians? And on this figure, you see the breakdowns by those who, the 21% in Egypt who say they definitely or probably would not get the vaccine, those who are unsure, and those who say they probably or definitely would accept the vaccine. If we focus on that group, this acceptance group first, you can see that the more influential sources of information are the World Health Organization, health workers, and government and friends and family. These are sort of fall in the top tier of influential sources. If you look at the refusers, those who probably or definitely would not accept a vaccine, you can see that they really trust no one as much as those who are willing to accept a vaccine or who are unsure. But even for those people who are more resistant, World Health Organization, health workers, and the government may be important sources of influence. Next slide, please. The same presentation for Pakistan shows a similar pattern with those who say that they are unlikely to get vaccinated. Again, the level of influence of these various sources is considerably lower than people who say that they are willing to accept the vaccine or are uncertain about that. But for those who are planning to accept a vaccine when it's available, again, we see the World Health Organization, local government, excuse me, and in this case, family and friends as being important sources of information about the vaccine that may influence the choice that they make. So, this suggests that we may need to investigate a little further which of the various subgroups, perhaps by demographic breakdowns, and the sources of information that they rely on to make their decisions about vaccine acceptance. Next, please. So there are a number of implications for communication campaigns, and this sort of brings together some of the things that Dominic was highlighting in the prevention behavior category, as well as some of the data that we find about vaccine acceptance. In Egypt, for example, hand washing and physical distancing are not as common as they should be. And so it may be important to focus on those preventive behaviors to help stem transmission of COVID-19. And also people seemed to be less aware of the benefits, the positive benefits of preventive behaviors. So trying to improve what is called the response efficacy, or the belief in the efficacy of these preventive behaviors, may be a way to strengthen hand washing and physical distancing in Egypt. In terms of vaccine acceptance, in Egypt, there's a relatively low acceptance rate compared to the global rate, which is 63%. Egypt is still quite a ways away from the level that can help to achieve herd immunity at around 75%. So it may be a wise strategy to focus on those who express uncertainty about vaccine acceptance as opposed to those who are outright opposed, because this group who is uncertain or reluctant but not strongly opposed may be more amenable to communication strategies, encouraging them to consider the benefits. In Egypt, we also noted some higher levels of refusal in rural areas and among women. So that suggests that these may be important subgroups to identify as intended audiences for campaign communication activities. And perceived severity is often an important factor in determining someone's willingness to undertake a protective health behavior. And this may be something that needs some further analysis in Egypt, where the perceived severity is relatively, or perceived threat is relatively low. In Pakistan, prevention behaviors are somewhat stronger than they were in Egypt. And so in terms of campaigns for prevention, this suggests that there may be room for a strategy that continues to reinforce and encourage those behaviors that are already relatively common. In terms of vaccine acceptance, Pakistan is somewhat closer to the herd immunity level. So again, reaching those unsure respondents, members of the public, and helping them to convert to a more positive attitude toward vaccines may help Pakistan quickly get to a herd immunity level when the vaccines become more widely available. And then some of the underlying drivers of choice, like level of education, gender, and where you live, may also be important to focus on for audience segmentation strategies. And like in Egypt, COVID severity perceptions are relatively low, so it may be important to try to help people develop a realistic assessment of the risk that they face, that they personally and their communities may face, as a way of motivating people to consider vaccines. And finally, the perceived threat associated with COVID infection may be something that COVID campaigns, communication campaigns, could emphasize, again, to provide more motivation for people to consider vaccine acceptance. Next slide, please. It looks like I'm finished, so I'll turn it back over to Rupali. Thank you.
Great. Thank you so much, Doug, and thank you so much, Dominic. Great to hear about the results specifically related to Pakistan as well as Egypt. We're going to keep moving. Thank you for those that are inputting questions. We will try to get to as many as we can. I am now going to introduce Lisa Cobb, who will give the next talk. Lisa Cobb is a Deputy Director from the Strategic Communication Programs Unit at the Johns Hopkins Center for Communication Programs. She is also one of the authors of Getting Practical, which is the result of a participatory process of input and feedback that was organized by Breakthrough Action, as well as the Learning Collaborative to Advance Normative Change. She has over 20 years of SVC experience, and she provides technical and practical guidance to staff across CCP in strategy management as well as implementation. So Lisa, welcome, and over to you.
Thank you so much, Rupali. I'm happy to be here. Okay, so we're going to switch gears a little bit here. Dominic and Doug have talked about data and what they mean. I'm going to talk about how to integrate what you know from those data into your programs. Specifically, I'm going to talk about social norms and SBC programming. Social norms can feel like really complex, and it can be hard to know what to do on a practical level, what steps to take. So I hope to give you some tools today to address that. You might wonder what social norms programming even looks like and how it's different from other program approaches. Here are 3 points to keep in mind. First, social norms are important, but they really aren't everything. Consider norms along with other drivers of health, like structural issues or ideational factors, the usual things you think about in your programming. Secondly, you don't need a special social norms program or a special social norms component. You can consider social norms as part of any SBC program. Third, integrating social norms into your program doesn't mean you must aim to change norms. Understanding how norms work and how they impact behavior is important. We'll talk about alternatives to changing or shifting norms later on in the presentation. Next slide. Before you jump in, I just want to mention a few things to consider. You don't need to be an expert on social norms to integrate social norms into your programs at all, but you should make sure to do your homework. There are 3 things I think we all should think about when we're integrating social norms into our programs. First of all, think deeply about ethics. Social norms are the rule book of culture, and it's unethical for outsiders to push norms change. The desire for change should come from inside the community, not outside of it. That can be really complex to navigate, and you need to think about it and plan for it ahead of time. I've linked a new article about the ethics of social norms interventions if you're interested, and I think Dominic's going to put that in the chat. Second, while you don't need to be an expert in social norms, you need to know the basics about what social norms are and how they work. Here are a couple of resources if you need them, sort of a primer, couple of good primers on social norms. Finally, do use data when you think about social norms in your programs, just like you use data with other elements of your planning. Okay, next slide. So after this slide, I'm going to go through a bunch of other slides with some tools and templates. Those all come from this new guide, Getting Practical. The guide was developed as a collaboration between Breakthrough Action and the Learning Collaborative to Advance Normative Change, and it was just launched earlier this year. Next one, please. A first step in using norms in programming is understanding the relationship between the behavior you are interested in, like mask wearing or physical distancing or vaccination, and a certain set of social norms. This template that you see on the screen is one way of organizing that information. The template also includes fields for other important information about norms. You see that it has boxes for reference groups, sanctions, and rewards, and other elements of social norms. If you were using this template to integrate social norms into a larger COVID project, you could identify half a dozen norms, or maybe dozens and dozens of norms that influence COVID behavior. You could then use this template to explore and document the characteristics of each one of those norms. Knowing that information will help you when you get to the point of message development and audience development. Next slide. Okay, I mentioned earlier that you can do more with social norms in SBC programming than just change them. This decision tree is a way to help communities explore their social norms and think about whether they would like to use those norms in any way in order to achieve that community's health goals. You'll see at the top, there are a few places you can end up once you've gone through the tree. First one you see there on the left is fortify, which means making the norm stronger or more common. Then there's reframe, which means thinking about the norm in a new way or connecting it to a new behavior. Then we have aware, which takes no specific action right now. And then we have shift, which is indeed changing a norm. Okay, next slide, please. One of the hardest parts of using data for SBC is making the jump between what you know from data and what you're going to do programmatically. This activity is designed to help you do that. So this activity is creating logic chain sentences. You probably know all about logic frameworks, which show how activities lead to intermediate outcomes, and intermediate outcomes lead to program outcomes. This activity has you create that logic chain, but in tiny form for individual activities. It helps you to articulate how an activity will use a social norm and how that social norm will lead to some sort of change. You'll see in the example given that you first write a logic chain sentence. So that's that sentence with blue bubbles around it. And then you diagram it, labeling the activity, the social norm, the reference group, and what will change. So this example is on reproductive health, and it comes directly from that guide. There's no magic to constructing these, and you can make as many as you can dream up, switching out social norms and activities until you come up with something that will work. There's a lot of art and creativity to doing this. These little sentences can be the basis of how you describe the use of norms in your program, showing people the relationship between your activity and the norm and the outcome, which can be hard to do. Okay, next slide. I'm going to give you two examples. Now these next two slides, a couple of very simple practical examples of using social norms to guide messaging. I have to admit that these examples did not come out of the tools and templates I just showed you. These are just little examples, sort of illustrative examples to think about. This first slide shows an example of how you might use the social norm presented in the data from Egypt and Pakistan earlier in this webinar. I've summarized that norm that Doug talked about as most people won't take the vaccine. As you saw in that presentation, the norm may be most people won't take the vaccine, but most people actually do intend to take the vaccine. There is a gap between the norm and people's intentions. So the messaging could show that most people do want to get a vaccine. That gives room and permission to act on people's own desires while also feeling like they were doing what is good and normal in their community. Okay, next slide. This one is an example that comes from real life, and I wanted to show it because I think it is important to consider norms that aren't directly tied to the health issue you are trying to solve. The norm on the screen, elders should be revered and protected, doesn't mention COVID or masks or injections, but it can be related to those things if we think about people's motivations for wearing masks and getting injections. This comes out of a campaign in Cameroon where the Breakthrough Action team was working with an ad agency to develop scripts for TV spots. One of those scripts showed young people talking about getting tested, and the team was trying to get at motivation for young people taking action when they aren't likely to get very sick or die from COVID. This norm of respect for elders arose as a norm that could be reframed or fortified in the messaging. This all happened during script review rather than concept development, so it was integrated in a small way. The idea of using that norm in concept development sort of earlier on in the process might result in messaging like, I am young and healthy, I'll get a vaccine to protect my parents and grandparents. Okay, and that's it. Nothing to it, right? Thank you for having me. Back to you, Rupali.
Thanks so much, Lisa. It's great to hear and talk through, I think, some great practical tips and give some great examples of how this has been done. So that has been great. We have a little bit less than 20 minutes for some questions. And so I'm going to go through, I think some of them have been answered in the Q&A. And so we've been trying to dismiss them as we're going through them. But maybe I can just start with a couple of broader questions if the panelists don't mind coming back on video for this last session here. One thing that I think would be really relevant, I think, to several individuals on this call that continues to come up, and there are questions related to this, based off of the data that you all have analyzed, have there been differences with regards to vaccine intentions by healthcare personnel? And the reason I want to flag this, and again, I'll turn it over to Dominic or Lisa or Doug here, but what's really fascinating is I think in other work, we have seen that there are stark differences with regards to willingness to vaccinate among specific healthcare populations, cadres of health workers. So maybe I will turn it over to the panelists to answer this question.
Doug, do you want to respond, or Lisa? Or I can say, unfortunately, we don't have a lot of information about healthcare workers in these data. We have noticed and been paying attention to some of those global kind of responses in the media and the reports around like 20–30% of healthcare workers kind of who are hesitant to actually take the vaccine. And yes, this is concerning because they're usually the people who we're coming into contact with to, make us feel more comfortable around the healthcare services that we are actually receiving, whether it's vaccine or otherwise. And so unfortunately, these data don't talk to that. But I do believe there are some studies that are actually linked through Facebook. Data for Good has sponsored a couple of surveys related to this, either by Sergo or another organization have been doing some work on that as well. I don't know if anyone else wants to chime in.
No, this survey is meant to be provide a snapshot and insights into what the general public is thinking about vaccines and about COVID prevention, rather than sort of specific professions or the healthcare system. So I think it's great. There are, I don't know if Dominic at some point you want to talk about the sort of the future of this survey and what's coming next, but this continues to be supported by Facebook, and there are going to be some continuing evolutionary changes to the way the survey is conducted and what it covers. So I think there may be opportunities to introduce some of these additional questions that you're raising.
Yeah, if it's okay for me to bring that up now, in April, we are merging this survey with another global survey that is called the Symptom Survey, and available under Facebook Data for Good. They've been supporting that survey and this one as well. And when we continue, we're going to have more frequent data collection and even a richer, kind of more robust sample in each of the countries that we're working in. And the number of countries we believe will increase to not just having the 67 countries with the snapshot, but actually more countries and having weekly data on some of these social behavioral determinants of behaviors, prevention behaviors, and vaccine acceptance. We've been working through and negotiating those different questions that'll be involved. There was a question earlier about why weren't religious leaders part of the response options in the trusted information sources. That's one of the things that came up and will be included in that next version of the survey. That was a great example of kind of how this kind of goes about. And you're always going to be wanting to tweak those surveys as you move them out. But the thing is that we're working to kind of evolve this even further. As well as evolve a new set of dashboards that makes it more interactive. And on our dashboards and on our pages, we have different ways in which you can give feedback to us. And we're really interested in that feedback and would love to find ways in which to kind of tailor this information so that it's more useful to you as the users and people in the field who are really kind of working in those RCCE committees or just advocating in your own community, either on a smaller or a larger level. So understanding how these data can be useful to you is really key for our success. Your success is our success kind of moving forward. So please give us that feedback.
No, thank you so much, Doug and Dominic. And it's great to hear, first of all, also, I think hats off, 67 countries is no small feat. So I want to say that this is a very rich data set. And I think several folks, I think maybe Dominic or maybe Marla did, also posted a link for individuals that are on as attendees that you can request access to the data, which I think many of us here would encourage folks to do so that you can take a look at this specific to your country. If I can switch gears just a little bit and ask another specific questions, there's two questions that are related that I want to try to squish together here if I can. As you all know, we've had different EUAs with regards to what are the products that are currently available for individuals to take. In the US, we have a very different environment where there is going to be a choice, essentially. We do know that most of us that are working in other countries, there's likely not going to be a choice. And there are some questions in the chat essentially about, are there, as more brands and as more kinds of vaccines and therapeutic products are approved, are you finding anything related to changes in acceptance? Are you seeing preferences with regards to 1 dose versus 2 dose? So I'll turn it over to you all.
So right now we don't have data related to that. It may come up in that next iteration of the survey. It has been discussed, and we'll try to figure out how to do that efficiently and in the survey in the appropriate way. And it's also something that it will depend a lot on the messaging and how those things are messaged in each community or each country, and figuring out ways in which to keep it positive and to make sure that people have access and understand whatever potential side effects or what have you are related to those things, and it's clear as the messaging goes out. I don't know if Doug or Lisa want to add to that.
I would just add that we have merged these data with some other available data like surveillance data. That's one of the figures that we showed indicated that while vaccine acceptance rates are going down, prevalence rates were rising. And so those data come from an external source. The prevalence data are not collected through this survey itself. So there may be some possibility of characterizing countries in terms of vaccine availability and the variety or the diversity of products that are available and to what level that could be overlaid on these data. But I guess I would emphasize that there is a lot in this survey, as Rupali said. This is a very, very rich data set, but it can't answer every question that you have, especially at the local level. So We encourage you to take what you can from this, play with the dashboards, explore it, get the data yourself, and do some analysis of your own, but then bring your own local wisdom to bear on how to interpret that and how to identify additional questions that you might want to try to answer locally through examination of other available data, or perhaps even some of your own localized studies that can help to shed light on these more nuanced questions that you have.
Yeah, no, thank you so much, Dominic.
Maybe, Rupali, I could just chime in with a reminder about the increasing complexity around formal approvals of the various vaccines. And that as some vaccines are approved and some are not approved, and they're rolling out in different countries, as communicators, we have an incredibly challenging role to work with governments and global bodies to ensure that we're able to communicate accurate information as much as possible. It just is a really, really complex environment, which you all know.
Yeah, no, I think it's a great point, Elizabeth. It's really a moving target, really, is the way this is going. Maybe I can ask a practical question that I'd like to ask each of you, and maybe we can have Lisa start. So what are some key things? You all are communication professionals. You've looked at these data. You have, as we've mentioned, this really, I think, rich data set that is telling us a lot. Can you distill down for us, right? What are sort of the key communication aspects that we really need to be thinking about as countries essentially are preparing in terms of from a readiness perspective for rollout of the vaccine? And, if there's just key sort of points, maybe 3 from each of you, that would be great. So we can think about some practical applications of this. Sorry, Lisa, not to start with you. I just wanted to make sure you had a chance to come in. So yeah.
I can start.
Okay.
I guess I wouldn't have any key things everybody must do, because all your situations are going to be different. But the need for flexibility and to be able to look at a context and say, what's going on here? What's holding people back? What are their concerns? What are the barriers? And then what are the facilitating factors? And so we got in my presentation, we talked a little bit about motivation. So what will motivate people, what their concerns are. I guess the second thing is being really respectful of those. And I think we can be a little flippant sometimes about people who are worried or scared. And so I think we should respect people's concerns. They're valid and they're deeply seated in their reasons for them. So I think just being respectful of our audience and of their needs, and then meeting them with communication. So being very responsive to that and using whatever access you have to data to track what people are saying, what they're asking, what they're wanting, and how they want you to communicate with them, and being responsive to those specific context needs.
That's great, Lisa. And I think some good practical advice, regardless of context. Maybe I can ask Dominic to give his insight next.
Yeah, as you asked the question, I was thinking back to one slide that Doug presented around, those vaccine acceptance responses on the Likert scale, and then what channels would influence people to potentially get a vaccine. And that, when we started to pull together those data, that was very revealing to me in terms of just how many different types of channels and different messages and different perspectives are included in this. And this goes back to what Lisa said a second ago, which was that it's about respecting people's perceptions and understanding of the health intervention, messaging to that understanding, and making sure that when they make their educated decision, that it's their decision to get vaccinated or whatever the health service is. But the thing is that we want to make sure that the messages reach them appropriately. They're worded in ways that are very understandable and clear and concise, but maybe address whatever that concern is that they may have, and utilize those trusted channels. And it's going to be different for as many people as there are in the world almost. So yeah, it's very complicated, but it is definitely, this work has kind of brought that complexity into perspective for me.
Great. No, thank you so much, Dominic. And I think the trusted influencer is a key point here, I think, regardless of countries. So maybe I can go to Doug next.
Yeah, one thing we didn't emphasize so much today is actually a really cool visualization in the dashboard, one of my favorites, which shows not just who the interpersonal influences are, but the media sources that people rely on and trust. And it's really fascinating to look across countries at which media people say they're getting most of their information from and the degree to which they trust those sources. So that's another an important strategic consideration, is to identify the sources that not only reach the most people, but have the highest level of trust and credibility for your population. The other thing I would highlight is, this survey was designed in a period when there were no vaccines available, and so there's a lot more. We have included a lot more questions related to the prevention behaviors and the way people regard those and perceptions of those and perceived norms and so on. We are building that out for the vaccine, for this new survey that Dominic described. And there will be more of those kinds of psychosocial determinants of vaccine acceptance going forward. But at this point, I would, with regard to prevention behaviors, I think it's really important to understand that typically people make these decisions based on a number of considerations, right? It's a combination of perceived threat and how effective you think prevention behaviors are and what you think other people are doing in your community. And so it's a combination of those factors that often really accelerates the uptake of prevention behaviors. We're in the process of developing several manuscripts that look into this in more detail, that will not only show, as one of the questions in the chat indicated, that certain variables are more important in some countries than others, but we're also trying to show that certain combinations of variables in certain countries can really make a difference. So it's important to tease those out, decide what's important in your country, in your location, and then leverage communication to address those multiple factors for a cumulative effect.
No, thank you so much, Lisa, Dominic, and Doug. I think we just have a couple of minutes left, and there have been a couple of questions specifically related to what do you all think are really the key drivers of hesitancy. So I'll talk just very broadly, I think, in some of the work that I have been doing, and it'd be great then to hear, we sort of hear the same kind of drivers. This was pre-COVID and post-COVID. So one is always vaccine ingredients. Number two is related to severe adverse outcomes related to vaccines, i.e. the misperception that a vaccine could lead to an adverse event such as autism. Three has always been low levels of risk perception. We have seen this time and time again. And the fourth that we're continuing to now push up, I think, to the top, which is also coming up in the chat quite a bit, is this idea of mistrust towards the healthcare system. And so I'm just curious, in the last couple minutes, if each of you don't mind commenting a little bit on what are you seeing now with regards to, can we bucket and think about some of the domains with regards to how the drivers of hesitancy you are seeing within this work? So maybe I'll switch the order this time, not to put Lisa on the spot first. Maybe I'll have Dominic go first, and then I'll go around. So over to you, Dominic.
Yeah, so recently we saw some shifts in acceptance levels from wave 14 to 15, and those, I'm not really sure. I can't really speak. I mean, some of the things you mentioned beyond those items that you mentioned before around trust and having the right information and those are kind of the critical elements. But our data are, what's interesting to me is like the changes over time, because as these vaccines are more available, does that instantaneously or does that naturally kind of result in increased trust? And as more people, and in my own personal life, I know more people who have been vaccinated. I haven't been yet. I'm waiting to go. But the point is, like, as I know more people who have been vaccinated, does my trust in the vaccine begin to rise? And so what is that relationship in terms of known individuals who have been vaccinated? Maybe it's celebrities who are articulating that online and kind of promoting vaccination through their own experiences. But I think that it's kind of that familiarity, and watching this change over time is really going to be key.
Great. Thank you so much, Dominic. Maybe over to you, Lisa, next.
Sure. I'm most familiar with the US context in terms of sort of what's going on with vaccine hesitancy. And I think what we've seen is that as the possibility of actually getting vaccinated rises, that hesitancy is falling. And so really this newness, the unknownness of the vaccine, I think probably has driven a lot of the hesitancy. And as people simply see that the vaccines roll out and that there are good outcomes and that rates of COVID hopefully drop, that really is going to be sort of the proof is in the pudding, and that's really gonna help people with trust, which is that second piece, right? And I think the trust with certain communities in the US needs to be re-earned. And there are quite good reasons for people not trusting the system and wanting to just have an extra moment to make sure that this is right for them. And so I think that gets back again to respect, right? Respecting the audience. And if we do those things, give it a moment, let the uncertainty, go by, I think we're going to find that vaccine hesitancy sort of not takes care of itself, but we'll be able to then address certain populations who have concerns that we need to address.
Absolutely. I think that respect piece is so critical, and I'm so glad each of you have brought that up. Doug, maybe over to you for the last sort of piece here as we wrap up.
Yeah, just very briefly, I do think the trust piece is absolutely crucial here. But I would also encourage people to not to try to focus on those who are most resistant. There's a large population of people who are uncertain about accepting a vaccine. And we know from, and Rupali, you can talk to this at great length, but we know that people who are resistant to an idea are often become more resistant if they're challenged. But there are, in most countries, there seem to be a large group of uncertain or unsure people who are literally on the fence about whether they would accept the vaccine. And I think it's really important then to look at who they trust as influencers and which media, which sources of information they rely on. And focus on that group, because I think by converting those uncertains, we can get very close to herd immunity once vaccines are increasingly available.
Thank you so much, Doug. And I think you're right. Kind of focusing on the population that can be changed and can be nudged or persuaded is very important. So I just want to thank, I know we're at time and I don't want to go over. I just want to thank each of the panelists. So Lisa, Doug, and Dominic. I also want to thank Elizabeth as the lead of Breakthrough Action for this really interesting webinar. There have been several links that have been posted, I think, in the chat. In terms of some of the resources, again, I think we would encourage folks to take a look at some of the resources as well as download and request for data. Because as Dominic, I think, mentioned, I think folks really want to make sure that people are able to access and utilize this data to help them tailor and inform their own communication strategies at the country level. And so with that, I just want to thank everyone for participating today. Thank you for your questions. Thank you for your engagement. And hopefully we will be in touch again at some point. So thank you again, everyone, and have a good rest of the day, night, evening, wherever you are. Thank you.
Thank you.